the presentation. Just let me start some introductory remarks. Thank you very much, Asham, for this kind introduction, and thank you very much, Sanofi, for giving me this opportunity to present this lecture. I think every day we keep discovering more and more aspects about basal insulins. Okay, thank you very much. So we keep discovering more and more aspects about basal insulin. I've just had two excellent lectures by Hemant and Jyoti on how, the evolution of basal insulins have occurred in a clinical practice. And not only that, are we sort of looking at just fixing the fasting and seeing how we can reduce glycemic variability. The greatest challenge is how we combine it with oral agents. And of course, once we move from basal oral therapies to basal boluses or basal plus therapies, how well we can adopt this from the patient's perspective as well as from the doctor's perspective. And this is where I'm really going to talk today about that. Can we retain our patients more and more on insulin therapy? Because that's where the greatest challenge lies when we introduce insulin therapy to our patients. So introducing it is good, but how many of them can we sustain it in the long term and keep them to the goals that we prescribe is the biggest challenge that we face in clinical practice. So this is going to be the overview of my talk. We're going to discuss about the how of basal insulin initiation in diabetes management, the why and how basal insulin titration in diabetes management, and titration inertia, is it a reality? Addressing the unmet need of hypoglycemia risk with basal insulins, addressing the unmet need of titration algorithm complexities with basal insulin, insulin intensification strategy, a stepwise progression towards glycemic control, and basal plus concepts and practical aspects. So let me address each one of these briefly and put an overview about the suggestions on how can we handle these problems when we see patients in practice. So let's look at the first one is let us understand the how of basal insulin initiation in diabetes management. Now, we all know that every individual is different, their requirements are different, and we can't sort of put them in silos to think that everybody should have the same insulin titration process or the initiation process, and how much of insulin do we need to give. There are many calculated formulas to derive how we sort of start the insulin dosing of a patient who's insulin naive. But here's one of them, that we can either do it from a body weight perspective or from looking at from the glycemic perspective. And here you've got from the body weight perspective. So you have three individuals, one with weighing 60 kilograms, 80 kilograms, or 100 kilograms. And here looking at the A1C value. So anybody with an A1C of less than 8%, the same patient, if you multiply by body weight into 0.2 units per kilogram, your requirement of insulin changes as a starting point. Similarly, if you have somebody who is more hypoglycemic and the baseline A1C is more than or equal to 8%, then you add a little extra insulin to the patient and you give a 0.3 units per kilogram. And similarly, the entire titration process of starting the the baseline insulin changes, and you can see from weight basis how much you can calculate the baseline insulin requirement of an individual patient. Now, we have seen some expert opinions as to how the titration process should happen. And there are two expert opinions that I would like to really talk about. One is the B-Smart expert opinion. And in this, what they really did was, they looked at the basal only, and they made it very simplified. So you begin with 10 units per day, or you titrate at 0.1 to 0.2 units per kilogram per day, depending on the degree of hypoglycemia. So the higher the baseline A1C that you've got, obviously you need a little more insulin for the patient. And if you have a lower A1C cutoff, then you probably require less amounts. So you titrate according to what the baseline A1C the patient comes to you. Or you start at flat 10 minutes per day, monitor the patient's fasting sugars, and then you go up with the basal insulin requirement depending on how much of a drop that you get. So if you get more than 30% drop of the fasting blood sugars, then you don't change the titration. You just allow the same dose to work. And if you find that there is a plateauing of the fasting value, then you probably go up on the dose. So you may require to titrate the patient's dose weekly or twice a week, depending on, of course, how your blood sugars are really doing. The other one is, of course, the Delphi expert opinion. And in the Delphi expert opinion, if you start with 8 to 12 minutes of basal insulin as an initial point, And then you give 4 to 6 units, or you can give a lower dose if hypoglycemia is concerned. So, patients who are sort of challenged in terms of their body weight or comorbidities or risk for hypoglycemia, you always underdose a patient at the starting point, because at the initiation point, if somebody experiences a hypoglycemia, it becomes a big deterrent for that person to continue insulin therapy. So it's more practical that you start with a lower dose of initiation, and then you build up on that dose, once you see the glycemic response. And some of them, we all know that they have a very, even with smaller doses of insulin, have a faster glycemic response. And these sort of patients is suddenly going through hypoglycemia. Again, if you have got somebody who, let's say, are renal compromised patients, they require lesser amount of insulin because the degradation is slow and there's a stacking of insulin that tends to happen. So in these patients, you probably will start with a lower amount of insulin for the patient. And then, of course, you sort of follow on a weekly basis the patient and titrate depending on the glycemic responses once a week or twice a week. The next step is, of course, let us understand the why and how of basal insulin titration. And here I want to talk about that why our patients sort of stop optimally controlled. And this was one study which looked at, and they said that almost 86% of our patients with insulins and oral agents, and approximately 80% of the patients who use insulins only are not at goals. Now that's a tall mark to really make. And what is the reason why patients are not at goals? There could be a progression of the diabetes, and there is a slow response from the clinician to react to that. So although you're getting a sort of a failure of the beta cells happening, more insulin requirements, but your insulin dosing is not keeping pace to how much the patient requirement is, and you're underdosing the patient. The other thing will be that there is an increase in associated comorbidities, or there could be insulin therapy which is required by the therapy, but you're not giving it enough, or you're not initiating in a timely manner. Or despite insulin therapy, the glycemic goals may not be routinely achieved, and that's one of the reasons that you may be sort of getting a suboptimal control. So you have to be proactive, you have to take steps early, and you have to constantly monitor the patients who are on insulin therapy for their glycemias to see how much of dosing an individual patient requires. Now here's a good graph which sort of correlates between the A1C responses, the fasting plasma glucose response test, and how much of insulin requirement the patient will tend to have. And you can see that if you sort of look at patients who are doing an optimal response or optimal titration process stepwise, and you see this sort of, you go from left to right, you see over here that A1C dropped from 9.3% all the way up to 6.6%. And if fasting plasma glucose dropped from 211 all the way up to around 130, you can see that this has been achieved by a stepwise titration of the basal insulin that the patient tends to get. So you can achieve targets provided you proactively up-titrating the dose requirement of an individual patient. So you can see here that the starting point of basal insulin is almost about 8.6 units per day, but to get effective titration goals, you have ended up giving almost about 30 to 40 units per day. And this has been a gradual up-titration process that we do, and see that your patient can get their response. We have different algorithms. So one of the algorithms, you can go 2 units per 2 days, or 3 units per 3 days, or 1 unit per day, and you can keep titrating the fasting plasma glucose till you get fasting blood sugar close to about 120, and then you can stop there. But that's a little sort of, if you're going too fast, there's always a risk of hypoglycemia that the patient can experience. So you need to sort of optimize how much titration you want to do given an individual patient profile. Now, this is basically a survey that was done with healthcare professionals and patients and their attitudes to basal insulin therapy. The key information was regarding the basal insulin titration, which, how many patients were getting, reacting to the information that was being given to them. So when they interviewed healthcare professionals, they said that almost 75% of the healthcare professionals discussed the titration process at the initial visit of the patient. And then the patients who were interviewed, they said that only about 16 to 28% of patients remember such discussions. Many about 32 to 42% are unaware of the need to titrate basal insulins. And only about 20 to 39 recalled the mention of time needed to reach glycemic goals. So you can clearly see the gap where the healthcare professionals are saying that we discuss it more than 75% and the recall by individual patients less than about 25%. So obviously there is a communication gap that's happening between the healthcare professional and an individual patient. And the message out here is that we need to have more proactive approach. We need to have a team-based approach by which our patients are counseled more often. They've been sort of decked with a clinic, with your team, who can keep talking to them about titration process of basal insulins and how they need to sort of document their blood sugar profiles and take necessary action of going up or down in terms of the dose requirements. Now, this was an enhanced study, and you can see here that there is an achievement of goals of university of less than 7% was achieved of less than 50% of the patient population study. And I'm sure that if we look at the Indian population, this is going to be no different at all. So why is it that despite all the tools that we've got, we're still not achieving adequate amounts of goals of treatment? So we need to sort of look at this more aggressively and see that how can we counsel our patients more effectively to see that more and more patients sustain the goals with effective amount of studies, effective amount of dose that we give to patient. This was another study, the IDNPS Wave 7 India subgroup analysis, and they looked at why was somebody sort of suboptimally controlled. And one of the reasons was the fear of hypoglycemia, which was considered as a key barrier. And if you look at the bar diagram on the right, two important reasons that stand out was lack of insulin up-titration, and the second was lack of experience in self-management of insulin dosing. And these are the two key points to prevent somebody from getting to optimal goals. So obviously, we need to teach our patients if there's enough data to show that patient-driven versus doctor-driven, what is the best titration. And we know that patient-driven titration is good and probably sometimes better than doctor-driven titration. And you have to empower the patients to learn the titration process and see how they can get their fasting goals much effectively. Because if you get your fasting goals achieved, it's going to translate into postal goals also getting achieved and the overall A1C coming down, into prescribed limits. Now this was another study which was basically an interview of top 5 physician perceived patient barriers to initiation and titration of basal insulin therapy. And they looked at what were the barriers from the physician's perspective. So patients' reluctance, unwillingness to consider basal insulin treatment was seen about 35%. Patients' non-adherence to existing medication regimes, or patients' inability to self-monitor the blood glucose in sufficient frequency. Patient concerns about out-of-pocket costs and patients' lifestyle into diet and exercise. Well, some of the major barriers that the physician survey reported were patients' inability to self-titrate and a barrier to insulin titration process. Now, we'll come to the next part, that do we really have something called the titration inertia? And let's look at what could be the three barriers that we talk about for titration inertia. We know that there is a progressive decline in glycemic controls because of the disease progression and the increased comorbidity that the patient may eventually land up with. And despite use of adequate insulin therapy in large prospective studies, the desired glycemic control is not achieved. So very often what happens when you have comorbidities, you tend to have a little step back approach that should I do adequate titration, should I suboptimally titrate, or should I go to the goals, and what are the risks that the patient is going to carry in terms of hypoglycemia, which may probably increase the chances of morbidity or mortality. So you tend to go a little slow in terms of titration and in the end result in suboptimal control, which may be one of the reasons for the progression of the comorbidity itself. So you've got to be very judicious as to, it's a kind of a tightrope walking that you're doing as to what should be your optimal control that you need to give a patient. So do not underdose the patient, don't overdose the patient and go slow in terms of titration would probably be the message that would be there from this kind of a situation. So I just want someone to say that what could be the factors contributing to titration inertia? It could be from the healthcare professional perspective, a reluctance, or because of the problem of weight gain, or the fear of hypoglycemia, or the effects of insulin therapy on quality of life, lack of education, lack of constant self-glucose monitoring, complex regimes, and this is one of the most important barriers that, when we give all kinds of complex titration regime to the individual patient who is not equipped to handle this sort of a regime, it's probably a situation when the patient says, I don't want to do it. And he just says, let me just go to more simpler forms of therapy. Or then, of course, if you are too tight in terms of the regime that you're giving and lack of flexibility in terms of dosing, then these could all be some of the reasons why somebody would, not titrate their doses, and this could be termed as a titration inertia. Now, hypoglycemia always remains a problem and a deterrent for us to go in terms of, intensification of therapies. And this is basically seen in one of the studies, where they said 2 out of 5 patients with diabetes reduce insulin dose after mild hypoglycemic episode. We know that hypoglycemia begins hypoglycemia, and one attack of hypoglycemia sort of predicts hypoglycemia. Because the patient underdoses, becomes hypoglycemic, he does defensive eating, gets weight gain, and all this ultimately results in hyperglycemia of the patient. And this was sort of, if they looked at it from the physician's perspective, in the form that this aggressive control is probably more out of caution with the diet tolerance than with the primary care physicians. So the consequences of the fear of hypoglycemia can result in decrease in tight glycemic control, poor adherence to therapy, reduced willingness to intensify therapy, and compromised compliance for taking therapy. And we've seen that this has been studied in different insulin regimes. So here's one where they looked at basal insulin versus premix. So they had very similar glycemic controls, but the risk of hypoglycemia was much higher with premix insulins. And if you look at the number of confirmed hypoglycemic events per patient years, whether it's overall hypoglycemia, symptomatic hypoglycemia, nocturnal hypoglycemia, all this was at a higher rate with the premix insulins. And if you compare ide-gas versus insulin glargine U100, there is almost about 86% higher overall confirmed hypoglycemia with ide-gas. This probably is because it's been driven more from the aspart from point of view rather than from basal to basal. So I think the increased risk of hypoglycemia comes from the aspart part of the co-formulations. But if you look at the percentage of patients who achieve an A1C of less than 7% without confirmed hypoglycemia, the U100 glargine stand out much better in terms of comparison with ide-gas. Now, we need to sort of address the unmet need of titration algorithm with basal insulins. And here's one couple of studies that how fast are you going to titrate the patient. So this study, inside Landline, treat to target, they looked at glargine U100, and when they were sort of the patients were very strictly and stringently controlled with tight algorithms involving stringent fasting plasma glucose or SMBG values. They showed that the attainment of glycemic goals was at the cost of hypoglycemia that was seen very frequently. But the same thing in the Atlantis and Gold A1C, where they looked at optimal glycemic control and they titrated slowly without pushing the patient to cause hypoglycemia, had better responses in terms of sustaining the patients on basal insulins. And here are some of the ways that you can titrate. So you could do a fixed dose titration process, or you can do based on fasting plasma glucose titration that you can see what you need to do. I just want to summarize to say that towards the end of that, some of the barriers to patient-centric approach is low level of awareness among both patients and physicians, constraints on patient time and resources, low rates of adherence to therapy, insufficient glucose monitoring using SMBG devices, undue medical and financial burden. So, you give too many SMBGs to be done to an individual patient. Remember, it costs, and each strip costs. And if the cost of monitoring is much more than the cost of treatment, then the patient may not really do it. So you've got to be very judicious in asking how much of SMEG profile that you need to give an individual patient, and how frequently, and if the patient is well controlled versus uncontrolled, how often are you going to ask the patient to do the point of care testing. Some of the main solutions that we can have is, we need to, as I just said, that we need to optimize our SMEG monitoring. We need to have more patient support programs to educate and handhold the patient when the patient is being initiated and intensified on insulin therapy. We need to have a motivation and encouragement for the patient to see that somebody is talking to them all the time. And they're sure, of course, that, as I just mentioned a little while back, that empower the patient to self-titrate because he knows best what he needs to do. And these, through various studies, show that patient-driven titrations are much better than doctor-driven titrations. Okay. So when you really stop titrating basal and add prandial insulin, when the requirement for basal insulin goes up beyond 0.5 units per kilogram per day, or you're not achieving your A1C goals despite having a target of fasting plasma glucose, or you find that you've achieved the fasting plasma glucose but your postprandial values are still on the higher side, that's when you need to introduce a prandial insulin for the patient. And when you decide that, you probably start with a basal plus. You look at the meal that gives the highest glycemic excursion, and you give a prandial insulin with that meal and titrate it so that you can fix that meal, post-meal glycemic values, and that may sort of, iron out the rest of the post-meal glucose values. Then you can do with just basal insulin with a prandial insulin. But if you find that the other glycemic values are still not at goal, other post-meal glycemic values are not at goal, then you can do with the second meal or third, and eventually the patient may require a full basal bolus therapy to be given to the patient. This is a study which looked at, of course, the glargine versus glargine plus blue lysine, so it was basal versus basal plus, and given basal plus, are you getting a better control for the patient? And this was the answer that they wanted to see. And here you can see in the point of care study that adding blue lysine to glargine further improved the glycemic control. You can see the control group and the intervention group, and you can see the end point. Despite that the A1C control is much better, and the percentage of people achieving a goal of less than 7% is far higher in the basal plus than in the basal alone therapies. So, you titrate the prandial insulin very similarly to how you do the basal insulin titration, and you need to go slow. Of course, there could be a meal-to-meal variation that the individual patient can have because there is standardization of what we eat, and there could be a meal-to-meal variation. So you may need to teach your patient, depending on, of course, what kind of food the patient eats, that you need to go up or down in terms of how much what you're going to eat. And this is where probably a prandial analogs come very much of handy, because if the patient is unsure what he's going to eat, then you can ask him to eat and then inject himself. So I want to end with some key messages that titration inertia due to fear of hypoglycemic weight gain leads to inadequate insulin up titration and poor glycemic control. Systematic yet patient-friendly dose up titration strategies with basal insulin helps achieve glycemic control. Simplicity and convenience of one's daily regime with basal allows the patient empowerment for effective insulin dose management in Indian settings. Progressive nature of diabetes may result in subsequent intensification of insulin treatment to achieve glycemic control. Rapid-acting and long-acting insulin analogs may link endogenous prandial and basal insulin secretion. A stepwise intensification of basal insulin glargine with single injection of insulin blue lysine can be considered in clinical practice. I think that's the end. Thank you very much for your patience.